Are you guys ready for the first
Oh,
paper
yes.
and the 2018 LLSA? Here we go. This one is called Intravascular Complications of Central Venous Catheterization by Insertion Site. It's by a gentleman named Jean-Jacques Parienti.
And in honor of the French?
Et al. In honor of the French, we are colonial today.
Colonial
it's by a
wigs.
small journal called the New England Journal of Medicine. You may have heard of it. Paul Jun is going to teach us some stuff about this. Take it away, Paul Jun.
Yeah, so this is a great study because it's an affirming study of what our common sense has always taught us in training, right? So whenever you put in a central line, what are the common complications that you're worried about?
Infection,
Yep.
DVT,
Yep.
mechanical, like pneumothorax kind of thing.
Yeah, or arterial injuries. So that's basically what you're concerned about. And now you stratify it by, well, if you did a subclavian versus an internal jugular or a femoral line, what are the rates of the complications associated in direct head-to-head comparisons amongst all of them? And so this was a cool study where there was a multi-center randomized controlled prospective trial and it involved 10 ICUs in France. Hence,
In France.
In France.
In France.
Every answer will be in French.
Oui.
And the primary outcome of this study was to look at the incidence of the major central line complications. And the major ones are primarily going to be the infection, the catheter-related bloodstream infections, or symptomatic DVT at the site of insertion. And they figured this out by actually culturing the catheter tip when they removed it, and at the same time they drew peripheral blood cultures. And then for the symptomatic DVT, within 2 days after removing the catheter, they ended ultrasounding it, compression ultrasound, to see if there was a DVT at that site of insertion. There were a lot of secondary outcomes, but one of the primary ones they're looking at was for safety, and it was rate of major mechanical complications. You're talking about like the arterial bleeding, the big red, or the big one, especially for subclavian internal jugular, pneumothorax, right? Because it kind of has a lot of secondary sequelae from it. And so, interestingly, some caveats to this study is that they used residents and staff physicians who had some experience, at least 50 insertions of central lines, and they're the ones that either inserted or supervised the insertion of the central lines. That's an interesting and important thing to realize or to recognize because of the third thing, which we're going to talk about a little bit more. But also another caveat was catheters. None of the central lines were impregnated with antiseptic or antibiotics. That's important to realize and recognize. The last part is that there's no randomization of ultrasound use or anatomic landmarks. So that was at the discretion of the person who's inserting it, whether or not they decide to use ultrasound guidance to insert the central line versus just anatomic landmarks. And we'll talk about that data when that comes up. A couple other caveats: they didn't quite reach the full study numbers that they wanted, and there's some data that was missing with regard to the cultures, but more so with regard to the ultrasound. You can see well over half of the cases of the central lines that were inserted did not get an ultrasound. And so there has to be some consideration for that when we talk about the results.
There was no instructions with the ultrasound in French. That's why I didn't.
Oh man,
that's part of
we're
it.
just going to get the letters you can't believe. Here, all right. Here is the important part where the rubber meets the road.
And this is where a lot of interesting things affirming what our suspicions were about common sense. When you use subclavian or when you place subclavian lines, there's less infection related with it, as well as less symptomatic DVT compared with internal jugular and femoral. Now, when you talk about safety and mechanical complications, again, pretty affirming. Subclavian, internal jugular, there are more mechanical complications, namely pneumothoraces, compared to femoral. Makes sense. I mean, it's pretty low. Other interesting findings when you slice and dice the data is when you look at the anatomic landmark use versus ultrasound guidance use. And you can see here that subclavian and femoral were more anatomic landmark use to insert the central line, which kind of makes sense as far as the training goes. But you can actually use ultrasound in subclavians in addition to internal jugular. And you can see why that can be important because there was a high insertion failure rate for subclavians compared to internal jugular and femoral. Time to insertion was about the same for all three. And so when you look at the primary outcome again, bloodstream infections that are catheter related, and the symptomatic DVT rates, statistically, the subclavian central lines had the lowest primary outcome incidence per 1,000 catheter days compared to internal jugular and femoral. And the risk, another way to look at the data was that looking at hazard ratios. When you look at femoral lines compared with subclavian or internal jugular lines compared with subclavian, there's a higher hazard ratio, 3.5, 2.1, that are statistically significant compared to subclavian. Again, specifically the primary outcome, infection and DVT. But you always have to temper that with the mechanical complications, right? Because we talked about there's a high number of subclavian internal jugular-related pneumothoraces. And they also noted when you slice and dice the data, there's a significant association between the use of ultrasound guidance and major mechanical complications. So quoting the study itself, there's a trade-off. And they say, quote, overall risk of mechanical infectious and thrombotic complications was similar among the 3 insertion sites. So they said it's a case-by-case basis. But just be aware that our common clinical sense suspicions are pretty much confirmed that subclavian lines are cleaner in the sense that they have less infection, less DVT, but they have higher mechanical complication rates. That being said, you really should use ultrasound guidance because it really can decrease the risk of mechanical complications. So to summarize everything in this article, again, subclavian compared with internal jugular and femoral central lines had less infection, DVT events, but it had more pneumothoraces. Really, if you can, use ultrasound guidance.
Doing this blind is old school, baby. Old school, baby.
Use ultrasound. Be clean. Subclavian's the cleanest. You get clotty, top and bottom, but with use ultrasound, you should be good.
And thank you, French people, for your colonial help in the American Revolution.
Fantastic.
And scene.